So, ladies and gentlemen, welcome to the morning. I hope you are not feeling too bad. I would like to alert you that the 1 in 2,000 risk of the acute pillow injury, I'm afraid, did afflict one of our number last night. And so if Group Captain Matthews has told me if his eyes are shut, it's not because he's not interested, it's because it's more comfortable. At the very outset, I'd like to thank my colleagues who have got together to put this day together for you. I also would like to thank Group Captain David Bruce and the EAG, because essentially this has come about from some correspondence that various of us have had over the years in terms of cardiology. And one of the things I think is important for the flight surgeons to be aware of is that a lot of the cardiologists train in civilian centres on a population that are clearly very different from those we are then asked to give guidance on when we qualify as consultant cardiologists. And I think there is a real lack of evidence generally in a lot of what we say, and one of the biggest things about this day is partly to hopefully give you an idea of how we approach the subject, but I think it would be fair to say for the cardiologists is also to give us an idea of what each other do, to try and come up with some consistent guidance in terms of the policy that is written on what is quite a difficult and contentious topic in often fit and healthy young people. So, without further ado, I'm going to do a general introduction which hopefully won't take much more than 10 minutes before introducing my colleagues. I think this is well known to all of you, and I don't want to teach you to suck eggs, but clearly cardiovascular disease has the risk of causing sudden incapacitation with its obvious threat to flight safety and mission completion. The other thing that is blindingly obvious, and we all know, is the fact that if you have a dual pilot operation, then that risk is to a very large degree mitigated, and therefore we can allow people to fly often with not insignificant cardiovascular disease in that kind of environment. But as we all know, the number of dual pilot aircraft, particularly fast jets, is decreasing, and the number of pilots we have is also decreasing, so that potentially actually each of the pilots that we have are proportionally more important and more difficult to replace. And this lays a certain amount of pressure on us to make sure that these decisions are entirely justifiable and as far as possible evidence-based. In the UK, and I'm sure in most of the other nations within this room, cardiovascular disease is the commonest cause for the loss of certification, both in the civilian and military world in terms of internal medicine. And careful screening and management of cardiovascular disease is essential if we are to maintain flight safety. Unfortunately, as these slides show, death may well be the first presentation, and clearly there is not a lot we can do about that if we haven't really looked in terms of our annual screening. And as I say, with 50% of people dying as the initial presentation, it is beholden on us to make sure that we routinely screen these individuals, and hence the requirement for annual, if not 6-monthly ECGs. And Wing Commander Hall yesterday discussed briefly the change in our policy in the UK, that when you become the age of 60, we add on the addition of exercise stress testing, but as you'll hear from my German colleague in a second, actually that is a process that is in fact used more routinely amongst all pilots in certain nations. But the other thing that is obvious is, of course, you don't need to die to essentially, in terms of from your cardiovascular disease, to essentially cause incapacitation that might cause you to die from losing control of your aircraft. And as we've also said the other day, actually the completion of the mission is equally critical, because there may well be people on the ground waiting for your close air support to mean that actually they can get out of the sticky situation they find themselves in on the ground. The key thing, I think, is that essentially the initial decision that must be taken must be that as with civilians. In essence, that actually the decision process that we go through must start at the basic clinical decision level. Clearly, there are additional pressures that we put on our military aircrew which may well require an additional myocardial oxygen demand when we put them in a combat situation or in the operational environment. And therefore we need to understand a little bit about the physiology that we put these guys through in terms of the aviation environment, and also bear in mind always that mission success is critically important here. As you will all know, there is a significant effect on cardiovascular physiology just by the effect of G. And clearly one of the things that we worry about is the fact that you may not need a significant amount of occult cardiovascular disease, particularly coronary artery disease, to have effects that may be beyond that you would find in someone in a non-flying in a civilian environment. G in itself is arrhythmogenic, which I will show you, and actually what we need to always bear in mind is the distraction and incapacitation that can be caused by these pathological findings. So a little bit of physiology, and again, I apologise for those of you who this is your bread and butter, but clearly G forces result in pooling, positive GZ forces result in pooling in the lower extremities, which decreases your venous return, and your heart therefore attempts to respond by increasing its heart rate, but you'd get an overall reduction in cardiac output as a result of the fact that your body's ability to overcome these high G forces is ineffectual in terms of time required. They can be overwhelmed relatively quickly, and this is worsened in push-pull scenarios. And as I've already said, the overall cardiac output may well drop because the body does not have the ability to respond in a timely fashion, given that these scenarios can be a fraction of seconds, whereas the natural evolution of the human body has been based on what we do at sea level. So as you increase the G level, as you can see here, your heart rate will compensate to a degree, but overall your stroke index is reduced to a degree where your overall cardiac output is reduced. And again, with a flight surgeon audience, I am aware that will be well known to you all. As I've said, the baroreceptor reflex is not a strong counterforce, and although you can physiologically overcome a higher level of G up to approximately an additional 1G, this is only relevant if it is applied slowly. And clearly the majority of environments that we put our fast jet crew, this is clearly inadequate. And as unfortunately the 10 to 15 seconds required for that reflex to kick in is not suitable when you lose your oxygen reserve to your brain in less than 5 seconds. So what do? Well, clearly we clinically assess individuals on an annual basis, or more commonly if there is concern. And clearly the other thing that's important is that history examination and the tests that we do are clearly critical in detecting the underlying conditions that we seek. And the routine ECG is an integral part of this, but the interpretation of that ECG in a young fit population, as you will see later today, can be somewhat challenging. So as I've said before, the clinical decisions really have to be the primacy here. Clearly, if someone has got chest pain, they need to be treated as you would treat a civilian with chest pain. The aeromedical decision, therefore, must be layered on top of that when we have dealt with the potential underlying cause from a clinical perspective. And of course, we screen people to try and pick this up early. And as my colleagues, I'm sure both Eddie and Christoph in a second will allude to, we do detect early levels of coronary artery disease, but there is some debate as to actually how best we quantify early coronary artery disease and how we go forwards. And I'm absolutely certain in the first 2 presentations you get this morning that there will be already a difference of opinion, which is important because actually there are more than one way of skinning a cat. There are really sort of 5 main areas that we're going to cover today. Coronary disease, valvular heart disease, again a highly contentious issue. Bicuspid aortic valves have already been mentioned by Major de la Rue the other day. And actually again, there are questions about whether we should, for example, prevent people who are incidentally found to have bicuspid aortic valves from joining the services. And again, I suspect different nations apply slightly different rules. And one of the biggest problems we've got is the fact that, whilst we all maybe have a handful of cases, what we really need to do is collaborating and actually putting all this evidence together and working together to make sure that we actually have the best evidence base to make these decisions. And again, even if we have very large databases, I mean, for example, the US have a 1.2 million ECG data set. Poor Eddie is not going to have time just to look at those, on his own. And clearly there needs to be some collaboration in terms of actually analysing this data as well. So today we have a wide array of cardiologists and individuals with a particular interest in cardiology to present. I'm delighted, as I say, to introduce all of them, and I will do that as we go through the day. But we have literally specialists in each area, including a cardiothoracic surgeon, which I'm delighted about, to give you an idea of the whole spectrum of cardiology. And I hope that there will be a number of questions that are generated from you guys in the audience, because you are the ones that deal with these guys on the front line. And actually what I really want to get out of this is, to have some idea of, the complexity of the decision making, and to try and give you an idea of how we think when we come up with decisions, which may not always at the first instance appear to be entirely evidence-based. So in summary, cardiac disease is common, and it may well result in in-flight incapacitation. Routine clinical and investigative screening will detect most problems, but it will also generate problems that cause us to scratch our heads in young asymptomatic patients. Most will require referral for a specialist aviation occupational opinion. And one of the things I say to my UK audience when I give this talk is that our civilian colleagues are very good at telling our single-seat pilots that they're sure that there is no reason why these conditions should not cause any problems, which then leads us into a situation where we then have to undo the damage that's been done. And therefore it is important to have, you know, the flight surgeon or the aviation cardiologist to give an opinion early to prevent miscommunication and often the angst that goes with that. I'm not going to take questions now. We will have a Q&A session at the end of the second session, so we will go through coronary disease and valvular disease first with various positions put forward from different nations, and hopefully if you've got questions please write them down so you don't forget them, because I would like to hope that the 25 minutes we have for questions is one of the more fundamental parts of the day where actually we can have a good interaction. I know the cardiologists will certainly have questions for each other, but I would actually like a lot of the questions to come from the floor if possible.